All right. Again, welcome everyone. We'll go ahead and get started. My name is Jordan Tolstoy. I'm a physician assistant at the University of Vermont Cancer Center and co-chair for this year's annual Women's Health and Cancer Conference. Joining me to welcome you and introduce today is my co-chair, UVM Cancer Center radiologist and UVM Lerner College of Medicine assistant professor, Dr. Elizabeth Watson.
We are so excited to be here with you this morning. Back in March, we weren't sure what would happen to this annual event. But with strong support from leadership at the UVM Cancer Center, we knew that we must find a way to make this important community education event happen. We would rather see you all in person, of course, but are so grateful to our amazing speakers, our planning committee, and all of you for making this virtual experience possible. Importantly, we want to thank our presenting sponsor, the Victoria Buffum Fund at the UVM Cancer Center, for their tremendous support, as well as the Eleanor B. Daniels Fund at the UVM Cancer Center, and the very many of you who donated when you registered for today's event. Philanthropy helps us to continue to create free, high-quality community education and support programming, so thank you.
As a cancer center, we are all committed to community education because we know it empowers patients, providers, and the public to better health outcomes. This event is unique in that we are all here together, learning together and from each other. For a successful day, we want to provide a few housekeeping tips. First, please be patient with yourselves and with our speakers and hosts as we navigate a technology-driven day unlike ever before. Things may not go as planned, and that's okay. We will make sure all content is available after the event on the Cancer Center website. Next, please participate. Your thoughtful questions enrich all of our learning. You will be able to submit questions through the Q&A function in Zoom at any point during a session. Speakers will do their best to get to as many questions as possible during the live Q&A portion. Outside of scheduled sessions, there is a library of content that is available all day to you, including yoga and meditation provided by Lonnie Poland of Vermont Reiki and Experience Yoga in Milton, Vermont. You'll find these sessions on the event website. Lastly, we want to recognize the many community resources in our region that with the UVM Cancer Center are here to support and care for our cancer community. You'll find many of them in our virtual exhibit hall this year, also available on our event website.
We hope you enjoy the day. Thank you again for joining us. I'm pleased to now welcome Dr. Richard Galbraith, Interim Co-Director of the University of Vermont Cancer Center, to introduce our keynote talk.
Good morning, everyone, and thank you, Elizabeth and Jordan, for volunteering your time and expertise to help create this day of learning for our community. I'm delighted to be here, and on behalf of myself and my co-director, Dr. Chris Holmes, I'm honored to introduce our keynote speaker, Dr. Helene Langevin. Dr. Langevin is Director of the National Center for Complementary and Integrative Health at the National Institutes of Health, a position she's held since 2018. Prior to that, she served as the Director of the OSHA Center for Integrative Medicine, jointly based at the Brigham and Women's Hospital and the Harvard Medical School in Boston, where she was also serving as a professor in residence. Dr. Langevin has strong roots here in Vermont, spending more than 20 years building her research in the Department of Neurological Sciences at the University of Vermont Lerner College of Medicine. I first met Helene about 20 years ago at a holiday party at my neighbor's house. She was playing the piano, another one of her skills, while everyone was singing. Later, she told me that she had recently been working as an acupuncturist, but she was interested in determining how acupuncture worked. And when I found out that she was also a physician with an outstanding postgraduate training in research, I suggested that she might want to think about using the Clinical Research Center at UVM. She did, and the rest, as you know, is history. As principal investigator of several NIH-funded studies, Dr. Langevin research interest has centered around the role of connective tissue in chronic musculoskeletal pain and mechanisms of acupuncture, manual and movement-based therapies. Her more recent work has focused on the effects of stretching on inflammation resolution mechanisms within connective tissue. She has authored more than 70 original scientific papers and is a fellow of the American College of Physicians. She received her MD degree from McGill University in Montreal and completed a postdoctoral research fellowship in neurochemistry at the Neurochemical Pharmacology Unit in Cambridge, England. Then she completed a residency in internal medicine and fellowship in endocrinology and metabolism at the Johns Hopkins Hospital in Baltimore. As NCCIH director, Dr. Langevin oversees a federal budget of over $142 million to lead scientific research on diverse medical and healthcare systems, practices, and products that traditionally were not generally considered part of conventional medicine. We are pleased to have Dr. Langevin in here to begin the University of Vermont Cancer Center's 23rd Annual Women's Health and Cancer Conference. She will share with us advances in research on the integration of complementary and conventional care in the pursuit of health promotion, resilience, health restoration, and disease prevention. Thank you for joining us this morning, and welcome, Dr. Langevin.
Pop up in the middle of my screen saying, is this okay now? Yeah. Can you all hear me? Yeah? Good. All right. So I'm going to go ahead and share my screen. Okay. Can you see this?
Yes.
Yeah, good. All right. Well, it is really an honor, a great pleasure for me to be giving this talk on whole person health as part of the Women's Health and Cancer Conference. You know, medicine has made such great strides in our treatment of cancer, which used to be considered a fatal diagnosis, but now can be managed in many patients as a chronic condition. So it is more important than ever that we learn how to support the health of the whole person through the entire health spectrum, especially in patients with chronic conditions. Now, so far, NCCIH has mainly focused on the use of complementary and integrative health treatments for managing symptoms such as pain, anxiety, and sleep disturbances. And this is, of course, very important in cancer patients as well. But today I will be talking about something different. I'll be talking about a new strategic direction that we are developing at NCCIH, which is whole person health. And as part of our, whoops, my slides are not advancing. Let me see here. Slideshow. Maybe I did not put it in slideshow. That's better. As part of our new strategic planning process, we have been re-examining what the NCCIH initials mean, starting with our middle C. The term complementary evolved from the term alternative and means treatments that are used together with rather than instead of conventional medicine. However, it's becoming increasingly tricky to distinguish, what is mainstream and what is not. For example, many conventional cognitive behavior therapy programs, for example, include elements of meditation or relaxation techniques. And also many physical therapists are cross-trained in, say, massage or spinal manipulation techniques. So, as part of this, of sort of re-examining this question, we've created this diagram where we've mapped out some complementary interventions according to where they fall within 3 broad categories: dietary, psychological, and physical, and where these categories overlap with more conventional domains, such as pharmaceutical drugs or devices. Now, the dietary category would include, for example, vitamins, minerals, herbal formulas, probiotics. The psychological category would include meditation, mindfulness-based stress reduction, or MBSR, and cognitive behavior therapy. the physical category would include exercise or manual therapy. Now, you can also see that there's some overlap between these, for example, the dietary and psychological categories, such as mindful eating, for example, and between the psychological and physical, such as yoga and Tai Chi, that have elements of both. Now, acupuncture is in an interesting place here because you can see that it sort of sits at the intersection of devices, because acupuncture needles are a device, physical and psychological, because there's clearly a psychological component to acupuncture. Now, in this illustration, the complementary treatments and practices are listed as single modalities, but in reality, they are often used in combinations. And again, the lines are increasingly blurred between conventional and complementary. So, for example, a combination of diet, exercise, and mindfulness-based stress reduction is commonly used in now some very conventional cardiac rehabilitation programs. Now, here would be an example that would be a little bit more complementary, where combining diet, stress management, and say Tai Chi. Now, this type of what we call multimodal therapy may include a mixture of conventional and complementary approaches, but in this case, the framework in which these are utilized is still very much that of conventional medicine. Now, in contrast, traditional Chinese medicine, or TCM, is an example of a multimodal therapy that can include diet, herbal formulas, Tai Chi, acupuncture, and manual therapy. In contrast to the cardiac rehabilitation example, TCM uses an underlying theoretical and diagnostic framework that is different from that of conventional medicine. And so we refer to this as a multimodal therapeutic system. And at NCCIH, we think it is important to study these systems as well as the individual modalities. And the reason for this is that both the individual modalities as well as the way that we put them together in systems can give us insights into aspects of human physiology and pathophysiology that we don't yet understand. Now, integrative health is at the boundary between conventional and complementary medicine, and being at the edges of something can be a good vantage point. We know that medicine has blind spots. A good example of that is what I've been studying my entire career, connective tissue, or fascia, which is basically absent from textbooks of rheumatology and orthopedics, but very much within the awareness of massage therapists, for example. Addressing blind spots will require the development of new phenotypic measurements for doing rigorous research. And for example, on the topic of myofascial pain, which we have recently, just a few weeks ago, addressed in a workshop at NIH 2 weeks ago. Another example is addressing missing connections between parts of the body. If you were to ask somebody who does yoga, is it possible that the way you breathe influences your digestion? I think a lot of people would say, yeah, probably. But if you do a PubMed search for anything respiratory and gastrointestinal at the same time, you get pretty much nothing. And so this is an area where I think we can have a lot to learn by looking at other ways of thinking about the body. There's another type of fundamental insights that could be illuminated by the diagnostic frameworks that underlie the complementary whole health systems. Imagine a patient whose signs and symptoms are represented by the symbols shown here. You could hypothesize that this patient suffers from a red disease, for example. Now, if you turn off the colors and focus on the shapes, you could think that the patient has a square disease instead. And this gets more obvious when you highlight the circles like this. But if in doing research on a treatment like acupuncture, patients are recruited based on color categories, but actual clinical practice uses shape categories, this reduces the ecological validity of the research. So over the past 20 years at NCAM and now NCCIH, we have learned that putting efforts into fundamental science and methods development is very important to ensure the success of complementary and integrative research in general. So we need to better understand how this applies to multimodal therapeutic systems as well as individual modalities. So we are not aiming for a new definition of the term complementary because that is likely to keep evolving, but rather to describe what NCCIH funds. So this definition aims to be inclusive and acknowledges some blurring of the lines between complementary and conventional. So now let's move on to the letter I for integrative. Now, what does integrative mean? We usually think of it as the integration of complementary and integrative approaches, and that's true. But we are also beginning to think at NCCIH about integration in a broader sense. Now, whether you're doing science or even philosophy or mathematics, there's always a back and forth between analysis and synthesis, which is synonymous with integration. In medicine, it's fair to say that analysis we're very strong at that. We really tend to gravitate towards analysis. First, because we study systems, we break the body down into systems, and that's the way medicine has been organized since its beginning of modern medicine in the 19th century. Cardiovascular, respiratory, digestive, etc., which has now led to the formation of academic departments and medical specialties. And within each organ system, we look at different types of cells, in which in each cell we look at different signaling pathways and molecules and all the way down. And so our tendency to break things down into signaling pathway molecules has sort of led us to a very sort of biochemical view of things. And so this predominantly sort of analytic approach to understand the body has led to a predominantly biochemical approach to treatment, which is pharmacology. Now, drugs can be life-saving, and we have made a lot of progress in medicine through drug development. But I would argue that what is wrong with our pharmacological method of medicine is not the drugs themselves, but that they are used in a non-integrative way. And I will illustrate this with the following example. Let's imagine a 35-year-old woman, first diagnosed with type 2 diabetes. She's overweight with a BMI of 30, and efforts to control her increasing blood sugar with diet over the past year has been so far unsuccessful. Her healthcare provider starts her on metformin and then glipizide, and 2 years later, her hemoglobin A1C is within a normal range, although her BMI is now 32. At age 45, she's diagnosed with breast cancer. She has estrogen-positive ductal carcinoma in situ and is treated with lumpectomy and radiation and started on tamoxifen and an aromatase inhibitor. 2 months later, she complains of persistent pain in her right knee and is concerned that the pain is related to her adjuvant therapy. An MRI shows moderately severe osteoarthritis, and she's advised to lose weight and take an acetaminophen and Motrin as needed. At age 50, she's off her adjuvant therapy, but continues to have significant knee pain, which has curtailed her physical activity. She's developed hypertension, which is initially controlled with hydrochlorothiazide and then requires an addition of an ACE inhibitor. This was discontinued 2 months later due to a persistent dry cough, and a beta blocker was added to her regimen. The cough symptoms improved after discontinuing the ACE inhibitor, but have not completely subsided. She also has a long history of anxiety, difficulty sleeping, intermittent epigastric pain attributed to gastroesophageal reflux. She's been prescribed Ambien to take as needed for sleep and Prilosec for her heartburn. She's concerned that her GI symptoms are due to one of her diabetes medications, but was strongly encouraged to stay on these because they were successfully controlling her blood sugar. She also has slight iron deficiency anemia, which is being worked up for a GI source, and she's been told to discontinue Motrin and take Tylenol instead. Now imagine this same patient 30 years later in a nursing home. Her diabetes and hypertension are still under reasonable control with a total of 4 medications, but her insomnia and chronic knee pain are increasingly problematic. She's not been able to sleep at all without medication for many years. She has had some cognitive decline, daytime somnolence, and worsening anxiety. In an attempt to wean her off the benzodiazepine, she was started on trazodone with some benefit, but has recently developed worsening tachycardia, which is being evaluated. She's had a GI bleed from erosive gastritis in her mid-60s and can no longer take NSAIDs, and she's needed stronger analgesics to control the knee pain, including occasional opiates for acute exacerbations. What's wrong with this all too familiar picture? She's not had a recurrence of her cancer, and so from that point of view, her treatment has been a success story. On the other hand, she is suffering from having been broken down into separate body parts. Each of her problems is treated as a separate disease, and the resulting polydiagnosis and polypharmacy create an additional layer of iatrogenic drug-induced pathology. Failure to understand the importance of seeing this patient as a whole person has led her to being treated using a fragmented, disease-focused model that encourages a reliance on pharmacologically controlling separate diseases rather than restoring health. This is a serious problem. The solution to this is obviously to point the arrow back towards the whole patient. But that's not easy. We are running into some confusion with definitions when we talk about this. The term personalized medicine started out referring to whole person, biopsychosocial human beings. And the term precision medicine referred to individualized treatments based on precise phenotypic characteristics, such as specific genetic alleles, for example. But increasingly, the personalized and precision tend to be used interchangeably to mean precision, and the whole person is getting lost. It's interesting that we are becoming increasingly aware of the interdependence of genetic and biochemical phenomenon, and we are moving in an integrative direction between, for example, genome-wide association studies and systems biology. We understand, for example, that pathophysiological processes like inflammation can affect multiple organ systems. But even these integrative processes are still essentially biochemical. But for physiology to be truly integrative, we need to understand the body in a fundamentally different way that incorporates biophysical phenomenon, connections between organs and systems, including connective tissue, which I will be talking about later this morning, and of course, between the mind and the body. Interoception is also an area that is ripe for more investigation and can give insights into connections between different parts of the body. How the nervous system senses, interprets, integrates, and the signals from within itself, such as hunger, thirst, tiredness, and proprioception. It's interesting to consider other ways to think about these connections. The brain does not necessarily need to be at the center of things all the time. One perspective, for example, gut-centric or musculoskeletal-centric, may also be important. Our growing understanding of the microbiome, for example, and how bacteria in our gut can affect our brains is illustrating this. It's also interesting to see how these three views map onto the dietary, psychological, and physical treatment domains that we looked at earlier. So in summary, I hope you can see the additional richness of integrative when it includes research on the whole person, as well as the integration of complementary and conventional care. So now let's look at the last letter, H, for health. I would invite you to consider these two plants. The one on the left looks healthy enough, but the one on the right looks like it's got some sort of disease. But what about the one in the middle? It doesn't look healthy, but one has a sense that with some better care, perhaps with less water or more sunlight, the plant could go back to health. One also has a sense that the transition from health to unhealth is reversible, but that is less so once it crosses into disease. In humans, we also recognize that there's a gradual transition between health and disease that can include a pre-disease period where abnormalities may be present but may still be reversible. And because people are not plants and we have some control over what we choose to do, such as what we eat or drink, there's often a behavioral phase that can precede this. And medicine is obviously very good at preventing and treating disease, and that's very much what we focus on. But we focus a lot less attention to understanding how we can move the green arrow back towards health, or what we call health restoration. For example, a good diet, a poor diet, can lead to pre-diabetes and eventually diabetes. And there is some debate about whether the line between pre-diabetes and diabetes should be drawn, and where to begin the pharmacological treatment. We also know that diabetes is often not an isolated condition, and this is because a poor diet can also lead to obesity and cardiovascular disease. And many of the same people who have a poor diet also have a sedentary lifestyle, and this plus weight gain predisposes to musculoskeletal pain and degenerative joint disease. We also know that many of the same people who have chronic psychological stress and poor sleep, which makes everything worse. It's very hard to be motivated to exercise when you're exhausted from lack of sleep. And of course, we're going to go for that plate of cookies in the afternoon if you're so tired. Now, once diabetes is established, they tend to be treated separately. Once all of these diseases have taken hold, and now drugs can be life-saving, but treating systems as separate often leads to patients taking multiple drugs for separate conditions, and frequent side effects, as was illustrated in the case history that I presented. Now, we're beginning to realize that many of these multiple comorbid conditions have common elements, one of them being inflammation. In patients who live with chronic conditions such as HIV/AIDS, for example, or rheumatoid arthritis, or inflammatory bowel disease, or cancer, reducing the body's overall inflammatory burden is very important, especially the components of this inflammatory burden that can be addressed without adding more drugs. Now, if we could rewind the clock and see what many of these chronic diseases have the same common behavioral factor: psychological stress, poor diet, insufficient physical activity. We need to understand better if and how addressing behavioral dysfunction at an early stage can potentially not only prevent the progression to disease, but also restore an improved state of health. In cancer survivors, reducing the overall inflammatory burden using self-care, dietary, psychological, and physical interventions as appropriate can help support a patient's whole person health. So what does whole person health mean? It means helping individuals improve their health in multiple interconnected domains. Now, by looking at the entire health disease spectrum, that's the horizontal axis here, in a bidirectional way, we can expand our understanding of integrative health to include the return to an improvement of health in addition to preventing disease. And by looking at connections across physiological systems, that's the vertical axis here, we can arrive at a better understanding of how comorbid conditions in multiple organ systems arise from interrelated dysfunctional behaviors. Now, we can also examine the potential role of multimodal behavioral interventions in addressing these problems and restoring health. It's also important to recognize that people can travel either way along the health continuum in both the psychosocial plane and the physiological plane, as illustrated here. And obviously, an important question is, how do we measure this? How do we do research on this? We've had a lot of outcome measures for negative outcomes like pain, distress, fatigue, disability. We're starting to develop a repertoire of positive outcomes like well-being and resilience, but we need more work in this area. It's also becoming apparent that symptom management is not separate from this process. A person with chronic pain that successfully uses self-care and complementary health approaches to stay active and improve their sleep can arrive at a greater overall state of health. We also need more work on the mechanisms of resilience and health restoration. Many chronic diseases, including cancer, are characterized by exacerbations and remissions. During exacerbations, the focus needs to be on controlling the disease, and drugs are the best tools that we have for this. But remissions are opportunities to move the needle on the behavioral factors that can lead to an improved overall health. Increasing evidence shows that inflammation is a systemic phenomenon, that inflammation in each organ system contributes to a chronic inflammatory burden that can affect the whole body. Similarly, behavioral interventions that reduce psychological stress or musculoskeletal inflammation offer an opportunity to reduce this inflammatory burden and improve health as a whole. We also know that chronic inflammation contributes to cellular aging, and reducing this could retard this process as well. So in summary, the H in NCCIH represents the entire health continuum, including health promotion and restoration, resilience, disease prevention, and symptom management. So I've just given you a snapshot of our current thinking at NCCIH. Our strategic planning process is still in progress, and there will still be a lot more opportunities for public input as we move forward. So basically, what we mean by complementary is that it includes complementary therapies, practices, and systems that use dietary, physical, and/or psychological approaches, and they have originated outside of conventional medicine. By integrative, we mean advancing the research on the whole person and on the integration of complementary and conventional care. And by health, we mean that we are fostering research on addressing research on health promotion, health restoration, resilience, disease prevention, and symptom management. This is a little bit of a new direction for NCCIH, but as you can hopefully see, this really incorporates the strong focus of the past 10 years that NCCIH has already made an investment in research on pain, mind and body practices, and also natural products. We feel like this was very important to put research on a very strong footing of strong science, methods development, as I indicated previously. That will then put us in a good position to propel this research forward and open up new areas of inquiry, including research on multimodal interventions and multimodal systems that use different types of diagnostic frameworks that we don't yet know how to investigate currently. So we want to develop methods to study these interventions so that we can have robust clinical trial designs, for example, that could look at these interventions in ways that are very, very rigorous. We have a lot of information. I'd encourage you to visit our website at nccih.nih.gov. There's a lot of information on the NCCIH website, general information for consumers, for providers and researchers about funding opportunities, for example, but also about complementary health approaches. And we have some apps, for example, the Herbalist app, which allows you to look up herbs, looking for or nutritional supplements. Importantly, there's a lot of information about potential side effects or interactions that these supplements may have with medications. Very, very important that people are very aware of this and always discuss with their healthcare providers if they're taking any nutritional supplements or any over-the-counter products, such as any natural product, for example. Something is natural does not necessarily mean that it is safe. And so there's a lot of information on the NCCIH website about this. We are also always, of course, responding to the current COVID-19 pandemic. We have issued some funding opportunities in response to the COVID-19 with, for example, we had some funding opportunities relating to the development of natural products that may be used that we want to investigate whether they might have some activity against the coronavirus, the SARS-CoV-2 virus. Also about stress in relation to COVID-19, because we all know that not only the consequence of the infection, but also the social distancing that we're having to experience right now is creating a lot of stress in people. And so how do we understand better the impact of this stress on people's health in general, but also on our ability to fight the viral infection itself is a very important topic. We also want to encourage you to follow us on social media. Our Twitter account, NCCIH Twitter account is here, as well as my own. Instagram, Facebook, etc. We really like to continue the conversation with you. We want to, if you have any input related to our strategic plan, we will be giving people some opportunities to comment on some draft of a strategic plan that we're going to be putting out to the public in a couple of months. And so we really are looking forward to hearing from any of you who might be interested. Thank you very much.
Thank you so much, Dr. Langevin. I'm Sarah Keblin, Communications Manager for the UVM Cancer Center. We're so honored that you joined us this morning and shared a bit about what's happening at the NCCIH and your work. Dr. Langevin will be providing a session at 10 o'clock for our health professions audience, and I encourage you all to join her then. As well as the rest of our participants, come back and meet us at 10 a.m. We have 4 sessions running. In the meantime, we have a wonderful virtual exhibits hall that you can visit on our website, vermontcancer.org, under our events section. And lastly, I want to encourage you all at the end of the day to pay attention to some post-event announcements that we have, including a post-event survey. Of course, we're always looking to improve this programming to support our cancer community here in our region. Thank you, everyone, and we'll see you back here at 10 o'clock.